Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry and promotes the highest standards of patient care with today's top experts in the field. Now here's your host, Dr. Joel Berg.
We are here today with Dr. Gustavo Oliveira to talk about aesthetic restoration of traumatized teeth. Dr. Oliveira received his DDS degree from the Federal University of Santa Catarina, Brazil, and a Master of Science and Certificate in Operative Dentistry from the University of North Carolina at Chapel Hill. Subsequently, he completed a clinical fellowship in the Department of Operative Dentistry at the same institution. He taught at the University of Louisville for several years before returning to Chapel Hill. He is currently an associate professor of operative dentistry and biomaterials in the Division of Comprehensive Oral Health and the graduate program director of the Advanced Education in Operative Dentistry and Biomaterials program at the University of North Carolina Adams School of Dentistry, Chapel Hill, North Carolina. Dr. Oliveira is a member of various professional organizations, including the American Dental Association, the Academy of Operative Dentistry, and the American Dental Education Association. In 2017, he was selected by the American Academy of Operative Dentistry as the recipient of the inaugural Rising Star Faculty Award. Dr. Oliveira is a contributing author of a leading dental textbook, The Sturtevant's Art and Science of Operative Dentistry, and has published many scientific papers and serves as a manuscript reviewer for several scientific publications. He's actively involved in research, and he maintains a private intramural practice dedicated to operative and aesthetic dentistry. Dr. Oliveira, thanks for being with us today on Pedo Teeth Talk.
Thank you very much. Thank you for inviting me, and it's a pleasure and an honor.
Well, I really look forward to our conversation, and because we're informal here at Pedo Teeth Talk, I'm going to, if you don't mind, call you Gustavo or Gus interchangeably. You said that was okay.
That is okay.
So I was excited to learn that you are participating in our pre-conference course in San Diego. So this is kind of a teaser to let people know if they want to know more information, they can go to your broader lecture on the subject, which is part of a panel of this pre-conference course on dental trauma. So and that's going to take place on May 26th during the annual session in San Diego. So before we get into that, maybe just a little bit of embellishment about your own interests. Operative dentistry it's kind of a niche field. All of us know what operative dentistry is, yet there still are only maybe a handful of programs in the U.S. that are graduate education, specifically in operative. So maybe you could just comment on what does an operative graduate program teach that you don't get in dental school?
Well, our focus is really on the aesthetic dentistry, but we also have a great emphasis in graduating residents that like to join academia, and so this is really we have a teaching component on the program that we emphasize a lot, and that's where people start to really love teaching. So we do have a little bit of actually a good chunk of a clinical component, and where we focus on the aesthetic aspect of dentistry, and a teaching component as well.
Thank you. That's good. You know, I've always seen operative as that teaching element. It's a way to train the operative teachers of the future in the advanced methods of restorative dentistry. So we're going to get into some of the specifics of how we fix these traumatized teeth. Before we do that, maybe just a quick review, some of the things we're going to hear about at that conference of the types of trauma that require restoration of various sorts. What are the different kinds of trauma that you think of in terms of a restorative solution?
Well, I think primarily the types of trauma that would have aesthetic implications, just not only to protect the teeth, but also to give a function and to restore function and aesthetics. So mostly that's what it is. Especially on the aesthetic component, some of the traumas can be very extensive. Still, we like to give back aesthetics and function as much as we can.
So when I think about the role of operative dentistry versus prosthodontics, is it fair to say that if one loses a tooth, the teeth are completely gone, avulsed, and they can't be replaced, is that still in the realm of operative dentistry, or are we limited to cases where the tooth or most of the crown is still there?
No, I would say it depends on the situation. We usually, um, I can think of one case specifically. So, let's say a child loses, or an adolescent loses a lateral incisor, for instance. We can help with a long-term temporary restoration, for instance, until this person is ready to receive an implant. Then we'll be on the placing implant and all of that is more on the prosthetic, prosthodontic side of it. But we can do, for instance, a Carolina bridge,
Yeah.
and this will be inside the scope of what we do.
So it was like Carolina, refreshing my memory here, because I actually did some Maryland bridges. So is that another name for a Maryland bridge, or is it different?
A Carolina bridge is basically a glass ceramic sponic. Usually it's done with feldespatic porcelain, and is bonded to the adjacent teeth. So basically, on a lateral works pretty well. I did Carolina bridges on actually a central mandibular incisor that worked pretty well as well. So basically, that's what it is. It's really relies on the bonding to adjacent teeth. So you got to have good connectors, good size.
I see.
Um,
So it's kind
good
of an
enamel
acid
as
etched bridge
well.
of sorts, just a variation of the acid etched
Mhm.
bridge, and that actually is a
You
good
got
way
it.
we should
Yeah.
think about interacting with you and your colleagues in operative dentistry, because we do encounter that
hmm
situation quite often.
Yeah.
Yeah, so I want to talk about the different techniques and different situations of restorative for aesthetics, because that's really the niche of operative dentistry. And I want to cover intracoronal versus extracoronal. We often make that distinction. And a full in the old days, you had trauma, you did a full crown. It might have been a porcelain fused to metal, then it was just a porcelain jacket, and now maybe it's a
hmm
veneer. So we've become more conservative
hmm
in our approach. But before I get into that, I do want to talk to you about those distinctions. The course on traumatized teeth doesn't talk about other reasons for aesthetic restoration that an expert like you might help us with. So, for example, developmental defects, incisor
hmm
molar hypoplasia that we're talking about a lot, fluorosis. And on the topic of fluorosis, when you and I were talking, I shared with you an article that reviewed 10 years laminate ceramics as opposed to
hmm
other methods of restoration, and they determined these ceramic veneers were actually the superior approach. So maybe you want to comment just on those very generally in the cases where we have discoloration, whether it's fluorosis or IMH, developmental defects. What is the state of affairs for restoring those teeth aesthetically?
So I would always, in my mind, my opinion, I would always try to go from a conservative approach, for the most conservative approach, to a more invasive approach. So nowadays, so microabrasion is here for quite some time already. For small developmental defects or opacities, mild opacities, it just can work very, very well. So microabrasion, macroabrasion, resin infiltration nowadays works so greatly as well.
Mm-hmm.
We have it's already on the science, published many times, and you can have excellent aesthetic
Mm-hmm.
results in a very conservative way. And um, uh, from that point on, I would personally use composites restorations where I can. Porcelain veneers are fabulous, but especially for younger population, I would say I would tend to go more with composites at first, and delay a little bit the more invasive procedure that is a porcelain veneer. Although they can work very well, but I would delay a little bit until they're older, and I would opt for a composite. If you're a composite veneer, if that's the case, that can always be later on. You can always have a porcelain veneer placed.
So when you say composite veneer, is that a direct or an indirect veneer?
A direct veneer.
Direct veneer.
A direct
okay.
veneer.
Do they still? I think I saw some products out there. They had sort of prefabricated composite veneers that you relined. I saw a few companies were attempting that. Have you seen that before?
I've seen those before, and personally, I tend to not use a preformed veneer or kind of a shell.
I see.
Really. I tend to do just with my hands, basically, just place the composite myself, and I can see it's more laborious to do a composite veneer than to do a porcelain veneer, for instance. But I think for younger generations, that might be more in the patient's interest, in my opinion, in certain situations. Evidently, a porcelain veneer is as well. If you compare to a full crown, it still is conservative approach. But I would personally, I would delay that if possible. I would delay that a little bit. The person can always get a porcelain veneer later on in their lives.
We will now pause for a word from our sponsor.
Do you need additional CE hours but don't have time to travel to courses? Did you attend the annual session and want to listen to the audio recordings? Check out AAPD's Education Passport, an online learning center, where you can earn CE and listen to audio recordings from all of our continuing education courses and more. Visit educationpassport.aapd.org.
We are back with Dr. Gustavo Oliveira. We're talking about aesthetic restoration of teeth that have been traumatized, but we're also covering the more general subject of starting with a conservative approach, as Gus is telling us, moving to more aggressive, even starting with approaches. You mentioned resin infiltration, microabrasion, don't even involve a burr, and then pick up the burr later, should you need to go there. So we're talking about veneers, direct composites being the starting point for young children until they get older. Mm-hmm. You're the perfect partner to work with us in pediatric dentistry, because we like to get through this transition to adulthood where they can maybe get implants and all the things that we don't do. So regarding the direct composite, this is your area of expertise. I've been to a lot of lectures in my life through various aesthetic experts, some colleagues that we mentioned, and I see them using, 2-3 layers and 3 different shades, and it looks kind of complicated. When you do it, it looks beautiful when we go to the lecture, but the ability of us to actually do that, maybe talk a little bit about how things have improved from handling standpoint, and our ability for the typical dentist or pediatric dentist to do these procedures in large areas, surface areas of like incisors where aesthetics is an issue. You know what I mean? Can kind of talk about how things have improved in our ability to do a good job.
Well, I think it's sometimes I believe in that we need to simplify dentistry, not to make it simplistic, but to make it realistic in a way that it's, again, like you were saying, sometimes we like to put those restorations that we use many shades to accomplish and all of that, and it looks beautiful, but sometimes clinically that's not really realistic. I think the composites are the main the technology nowadays that it's being used for composites, really the main improvement, technological improvement that helps us to get better aesthetic results, I believe. I think you don't need many shades. Many times you don't need many shades to restore teeth. As a matter of fact, sometimes you only need one shade. And it depends on the characteristics of the tooth that you are trying to restore.
I see.
But I believe that sometimes 8 shades might be too much, and sometimes one shade might do it.
Yes.
But the beauty of composite is, even if you're using just a few composite shades and you believe that your aesthetic result wasn't exactly what you're looking for in the beginning, you can always go back and redo it, just remove a little bit of the composite if that's the case, or just remove some more and just redo it. That's the beauty of composites, really. You can do it as many times as you wish, to a certain extent, until you get a great aesthetic outcome.
Right. Yeah, I mean, in
Yeah.
pediatric dentistry, we see so many patients in a day. You know, we're seeing 40, 50, 60 kids a day, and maybe or more, and maybe 10 or more of those are restorative procedures. So we're always looking for the juxtaposition of an effective result, aesthetically and
Exactly. Yeah.
physiologically effective.
Mhm.
Yet it doesn't take too long. So that question I asked you was in that premise.
Mhm.
So I will be looking.
It has to be
Yeah,
realistic.
realistic is a good way of saying it, and I think we're going to be looking forward to your lecture to hear some of that realistic restorative approaches, and maybe phased. What do I do today versus 3 years from now? That transition is really important.
Yeah.
One thing that's related to this subject that we get asked about a lot as pediatric dentists is whitening or bleaching, and that's a phenomenon. It's there's some abuse of whitening by maybe teenagers a little bit, some of the over-the-counter products. Maybe just very quickly in the moments we have here, tell us about what's this? What are the updates related to call it whitening or bleaching, home care, OTC products versus professionally delivered? What should we know about the latest in that subject?
Well, the bleaching has been really in the market for such a long time. I think if I remember correctly, the main article published by Harold Hyman and Van Haywood was published in 1989,
Right.
and we've seen a lot of improvements from technological improvements from that time. But the main principle is still there. So even with OTC products, many of them work. The whitening strips, they work. It's always an equation of time and concentration of the bleaching product. OTC products, they do work, but they tend to be milder than products that we use in office, or even supervised by dentists. The good side, or the advantage of having a bleaching done supervised by a dentist, is that we can control things a little bit better than OTC products. And we can do our bleaching trays. We can control the concentration of the gel that is being used. We can follow up with the results, and even the mild transient issues that the patient may have.
Sensitivity or something like that. Yeah.
Yeah, yeah. Usually they're transient. So tooth sensitivity and gingival irritation are the most common issues observed, but they're usually transient, and we can control. The dentists are aware and can control those better. But OTC products, they also work, but you may require it may not be ideal for every situation. There are publications on this, but usually the studies are done with perfectly aligned teeth, and so there are limitations for those whitening strips, and you may need to use many to get to the shade that you would like.
Yeah, and then there's the concentration part and the sensitivity and all that stuff, because those are pretty low concentration if they're OTC compared to what you're able to deliver professionally. So what about the timing and interface between whitening? Patient wants their teeth whitened, but they have a fracture or they have some trauma, and you want to do some restoration. It seems like should be the case that you want to whiten first and then restore. But if they have a big gap or fracture, like a class 4 fracture, then you don't want them to go too long. So how do you manage that case?
Yeah, what you can do. So the main issue that comes to mind is sensitivity, right? aesthetics and function as well, but sensitivity. So you might need to just to seal the dentin over there and do the bleaching, and then after that do the final restoration. So again, materials don't change color, right? Just tooth structure. So if you're facing a situation where the patient comes to you with a large class 4, and the patient expressed the desire to have the teeth bleached, I would probably protect the dentin with even a flowable might do it, and do the bleaching, and you can get excellent results in 2 weeks, 1 to 2 weeks. About 8 shades, you can improve about 8 shades in just a week.
Wow.
And then after that, you bring the patient back, take a look. Usually, you will do your restoration about 1 to 2 weeks, to be on the safe side, 2 weeks after your bleaching is completed, just because the bleaching agent will interfere with the bonding procedure. So, and after that, you can complete your class 4 as you would normally do.
Yeah, I think we're confronted with situations where, the patient, the parent wants immediate fix of a situation, but it's not in their best interest. I mean, we were trained, tell me if this hasn't changed, that really don't want to put a burr on that tooth where the pulp might be, there might be a concussion, and we want the pulp to kind of calm down. We don't even want to get the bevel on the margins right away. So what you said is, just to seal it with something, and some composite without much preparation would probably be a good idea anyway, right?
You got it. Exactly. I would just seal it. You can't, in the worst case scenario, if there's a concern with the aesthetics, you can put a class 4 restoration, as long as the patient is aware that it will likely need to be redone once the bleaching is completed.
Exactly. Okay. Well, it's kind of like, reminds me, when we encountered as a resident kids who were in a motor vehicle accident and broken bones. They're in the hospital for a week, but they also fractured and some incisors. So when they come to the hospital, the last thing on their mind is those fractured teeth. When they leave the hospital, that's the most important thing. So it's kind of like sets up this scenario in general of, we need to be planning and not ignore that even in the midst of overall trauma. And when we talk about trauma, it does occur not just to the teeth, but to the body. So we need to think about that juxtaposition of treatment. So you give us something to think about as we revisit this subject. So in our last moment here, Gustavo, can you tell us like what a big trend in restorative dentistry, aesthetics, what would you say the exciting future is going to bring us?
I think one thing that we are seeing right now, it's the introduction of universal shade composites. This seems to be a trend in the operative restorative world, and it's trying to look a little bit on it. It doesn't have, I don't see many studies still out there, but this seems to be a trend in the composites.
Wow.
Composites world.
I see those advertised. Yeah. So they might work, you think? There might be something big there?
Well, it's maybe. If you think about it, it's how many percent? What's the percentage of people with an A2 shade?
It's like 90 for 80 us.
Some percent. Yeah, exactly 90. So chances are, if you use an A2 composite, chances are that you're going to be pretty close to your final shade. But I really don't. I have to still have to look into those and see if they would give the aesthetic in terms of the composite, in terms of the mechanics. I'm sure it will be fabulous, just like the other composites that we have, or at least comparable. But in terms of the shade matching, then I don't know. We really need to use it and see how this will be. We have been using a variety of shades for such a long time, and once you start, I always say that the best aesthetic results with composites are achieved by the people that are so familiar with the system that they know exactly what they need to use when the patient comes in. So we'll need to see. We need to use it and see how it how it goes.
Well, that's particularly exciting for us in pediatric dentistry for the reasons I mentioned. So that's great news.
Yeah.
Well, Dr. Oliveira, thank you so much for being with us today on Pedo Teeth Talk.
You are more than welcome. Thank you for inviting me. It was fabulous. Excellent.
We'll
Thank
look
you.
forward to your lecture coming up here.
Definitely. Pleasure and honor.
Do you need additional CE hours but don't have time to travel to courses? Did you attend annual session and want to listen to the audio recordings? Check out AAPD's new Education Passport. The redesigned and improved Education Passport is AAPD's online learning center, where you can earn CE and listen to audio recordings from all of our continuing education courses and more. Visit educationpassport.aapd.org for more information. For 10% off any product, use discount code TEETHTALK in the Education Passport store. Pedo Teeth Talk is the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. Be sure to check out previous episodes of Pedo Teeth Talk, as well as our other podcast platform, Newly Erupted. All previous episodes are available on our website. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.